People get results when someone guides them and supports them through the process.
No, when they get scared.
We are living very unphysiological lives.
For me, it's a dead-end road that's only going to get worse.
I think there are very few people left today who don't suffer from chronic stress.
What is the mechanism by which these two things are connected?
Addiction to dopamine or serotonin or addiction to stimulation is here to stay.
The psychotropic drug can get you out of that.
I've seen some cases that have had side effects.
It should always be prescribed when lifestyle changes have failed.
You still need to consider if the person has mitochondrial dysfunction.
What would you do if tomorrow you get a blood test and see that your 6.7% is at 6.7%?
I stop eating.
Old school doctor fixes everything by fasting. That's very dangerous.
Very dangerous for the general public who don't know how to interpret it, or very dangerous for Google.
In the end, your mind overthinks a lot more.
It's fine to know many people obsessed with health.
For better or for worse. For better or for worse.
Javi, Borja, thanks for being here. I know it's a logistical problem for the three of us to be here on the channel, but I'm taking advantage of this situation, which is very special, to discuss a couple of topics that I know are useful for everyone. One of them has to do with the fact that we increasingly feel like we lack enough energy to do tasks, even the necessary ones of daily life. So, in some way, we need to have strategies to address chronic fatigue, the lack of energy that we see. More and more people are complaining about this. Also, we know that it makes it harder to maintain our habit changes, improve our diet, and do the exercise we need to do. I mean, it's a negative effect that impacts all other areas of our health. So how can we address this from each of your strategies? Or how do you think we can address chronic fatigue? Javi, what do you think we can incorporate as strategies or routines to mitigate the damage caused by fatigue?
For me, the key is sleep, because what I see most in people when they lack energy is that they can't sleep. We still don't fully understand that in order to get restorative sleep, it's called restorative sleep for a reason, because when we sleep, we allow part of the brain to rest. But above all, what we do most is repair our tissues, our digestive system, our brain, the lymphatic system. And when we don't sleep, everything goes backwards, especially when it comes to mitochondrial energy.
Yes, if I keep pulling the thread, we should ask ourselves why we're sleeping worse and worse, what's going on. And I think that basically there's something I've been paying more attention to lately, which is called chronic sympathetic hypertonia, which basically means that the sympathetic part of our autonomic nervous system is overactivated because we live in an environment that makes it easier, that encourages it, which has a lot to do with what I talked to you about, Sebas, that constant overstimulation. So I think there are very few people nowadays who don't suffer from chronic stress. Very few people, I really mean it, at least in populated areas. So basically, we're living lives that are not very physiological, very far from what is expected of us. We set an expectation, you talk about this too, Sebas, a very high one regarding what a normal life is. I mean, a normal life doesn't mean you have to have 15 hobbies, do 3 different sports, work 10 hours a day, have a family, have 3 kids, do everything well. It's impossible. Impossible.
Maybe that's the most common thing.
Of course, but it's impossible.
This thing about always pulling the rope until it finally breaks, and you end up saying, but why did I end up with this guy?
But it's crazy, but it's a normalized kind of crazy because you see your neighbor doing it, you see someone else doing it too, and you say, why should I be left behind? But honestly, I don't think that's a healthy way to live. I don't know.
Quite the opposite.
Why chronic stress? We all understand that chronic stress affects our energy levels. Maybe someone, even if they don't realize it, has experienced it in their own body because they noticed they got sick, because they noticed they feel worse, because they noticed. But what is the connection or the relationship that you see in terms of, well, what is the mechanism by which these two things are connected? Why does being stressed or emotionally exhausted also affect my physical energy? Because
for the same reason that too many reels or vertical content demotivates you. That is a desensitization to glucocorticoids and catecholamines. That is, your body is exposed to such superphysiological amounts of stress hormones that it stops responding to them. And therefore, you need a bigger and bigger and bigger stressor each time to respond.
But for me, that's something there's no turning back from. For me, it's a dead-end road that's only going to get worse. So, I think we're at a point where we have to look for which path to take that addresses that catastrophe. Because addiction to dopamine or serotonin or addiction to stimulation is here to stay.
yes, what role, if any, that is significant enough to make a difference can adaptogens play in this situation to help mitigate that adrenal damage, that damage to cortisol? Are they enough? People often use it as a crutch to fix chronic stress. The real question is, does it actually help with fatigue or chronic stress from a practical standpoint?
I'm very honest, I use them, have used them, and even sometimes recommend them to patients. But for me, taking 600 milligrams of ashwagandha in this context is like trying to empty a swimming pool with a bucket of water. I mean, you could empty it if you spend 4 days doing it, but honestly, it's not very cost effective.
No, it doesn't exist. I agree 100%. Many times people tell me, no, but give me ashwagandha, give me rhodiola, give me gamma-aminobutyric acid and melatonin. But that's never going to cover up the mess, that chaos we have. No.
Relax, speak Argentinian, okay?
But you know what Colombo means? Yes.
Yes, everything.
It has different meanings in other countries, which is why I mentioned it. I think we have the knife under the pillow syndrome. This is something I heard from a patient a long time ago, and he told me we're always on alert, that we're constantly stressed. Actually, our neurocognitive physiological system, which is the same as it was thousands and thousands of years ago, ends up being in a state of constant alert and alarm. So we sleep paying attention to the environment because of the overstimulation you just mentioned. So there's no way to lower that vagal tone, no matter how much you want to eat, sleep, digest, or go to the bathroom.
And also, many times the things that naturally lower that sympathetic tone and raise the vagal tone, we've removed from our lives. Nature, having some exposure to sunlight, contact, which in the end, we're more separated as a society than people used to be. The other day I went to a place, there were 20-year-olds at the club with the music, all looking at their phones or vaping, but they weren't dancing. I mean, they weren't touching each other. No.
The vape burns out, right?
Yes, we talked this morning.
You talked.
But
please, I'm tired of that.
I mean, these are things that it's normal for us to be like this. If you look back and zoom out, it's normal for us to have chronic stress. It's normal because, I don't know, I'll say it again, we've normalized things that aren't normal. So either we break down or we find a way to reconnect with who we are.
Finding a way is important for chronic fatigue, as it's different from just viewing it as sympathetic hyperactivity, where you're always nervous. But on the other hand, from the chronic fatigue side, there's a problem that has to do with experience and empiricism, which is that every time we reduce that sympathetic hyperactivity, as we increase our level of relaxation, at least in a shorter period of time, our energy level drops even more. So from an empirical point of view, something very interesting happens, which is when I'm thinking, from the lens of chronic fatigue, I'm actually looking for that effect, which is never sustainable, of more stimulation to try to fix it. You know, Javi, before off camera, about the mitochondrial effect or the mitochondrial importance in terms of energy production. You have to take into consideration anyway, if the person has mitochondrial dysfunction and if they have the capacity to produce energy, if there's an obstacle affecting the following steps, this energy can't fulfill its function. And also from the point of view of making the process in the long term adaptive to increasing my energy production, if I never train at zone 2 level, never train at the aerobic level, etc., my production of new mitochondria is much more complex, and at the mitochondrial level, I will always be lacking adenosine triphosphate.
It might seem like I'm kind of a downer, and I am a bit of a downer, but I see everything more negatively. It's like the example that comes to mind is when someone says, I'm going to tire myself out so I can sleep better. And the irony of saying I'm super tired, I can't take it anymore, I spent the whole day working, exercising, I was busy with a lot of things very intensely, and at night we sleep worse. I mean, this is how I feel. In order to achieve good mitochondrial function and repair those very cells that are going to generate energy, we need to slow down, not keep speeding up. Why do you talk about zone 2? At what point are we talking about increasing the intensity to give energy to mitochondria that are already depleted?
Because in specific circumstances of chronic stress, it helps me as a way to release stress.
Yes, there is.
Me too, it's a more natural mechanism.
I agree with Seba in the sense that within aerobic training, in a situation of chronic stress, zone 1 would be walking, zone 1 would be taking a stroll with the dog, and zone 2 would be a very light jog, something that requires very little recovery afterward. I would never go for high intensity in a situation of chronic stress or chronic fatigue. So yes, I think it can be, Javier, a useful tool, but obviously we need to go deeper and use other tools as well. We need to do much more than just physical exercise. The thing is, when you have chronic fatigue, everything that would give you more energy in the long run isn't something you think about doing. because you have chronic fatigue, you know? That's the vicious cycle that a lot of people can't get out of.
That's why I was saying when I talk about this, I always imagine talking to someone who's completely drained, who has no energy, who doesn't have any more resources. And I tell them, well, let's start going to the gym. Let's train in zone 2 and zone 1, go out for a walk. No, they're at 0. Speaking of that, yes, I think supplements can help us stay afloat. At that moment when we're already completely out of energy and with a deep mitochondrial failure, I think an adaptogen can be useful.
Yes, it can be useful. It contributes a small percentage, in my opinion.
Sorry to interrupt, but which do you think is better? The supplement in general, not the adaptogen, the supplement in general, what is better? Which one is more effective for boosting or for getting out of a slump?
What is an adaptogen or any other?
Any supplement.
It depends on the supplement. For example, if you're under chronic stress, taking 400 milligrams of caffeine might make things worse.
Especially if your adrenal gland is activated.
Of course, which is exactly what most people do. I have no energy, I can't even get there, so I take a pre-workout to train, or I take caffeine, or sometimes I even take stronger stimulants. So, going back to what I said before, I think in that situation it's very difficult, but you have to try to reconsider what's going on. There are clear organic issues to address when we experience fatigue. It could be iron deficiency simply, which is the most common. But when we've already ruled all that out, many times it's due to a bad emotional situation, problems at home, problems in the family, or a bad work situation. You have to pull the thread, and sometimes the doctor must also act as a psychologist, just as psychologists sometimes venture beyond their usual areas. I don't know what you think, Seba.
No, there's not for me. There's no defined path when it comes to fixing this. Yes, I think it's a process we all need to recognize and get comfortable with, since it will become increasingly necessary for repairing energy production. There are many tools, but from the supplementation point of view, I agree that it does help sometimes. Javi, especially for someone who can't do anything anymore, that first boost generated by supplementation, what could that be? It can be like a small motivator to show that it's possible to achieve a result, to have a change. From that perspective, I do think that creatine, that starting to use things we know increase the level of energy available at the cellular level, has a positive effect, as long as they're accompanied by elements that allow you to sustain it over time. Change of habits?
I feel that the first tool, at least the one that works best for me to understand whether that person is going to come out on top or keep sinking, has to do with stopping eating. I discovered that it's easier with people who maybe have energy disorders to tell them, stop eating, and maybe they take it as a sacrifice, but they can do it rather than changing their diet, because lately with modern diets it's very difficult, especially because of choosing due to availability. So when they stop eating, maybe for a period of 12 hours, that's enough to start generating a bit of a metabolic switch.
To make intermittent fasting a bit more acceptable, yes. Most people will respond well to that, except for athletes who already have a situation of low energy availability. It can be a good start. It's also a way to give the person control and get them to take action. Sometimes when you're, like you said, overwhelmed, what you need is, tell me one thing I can do, I'll do it, and once I do it, I'll feel good tomorrow. And from there, you're already at level 1. From there, you can start working. You can do a little better.
There you're bringing up a very special difficulty anyway, since we started looking at it as a project, which isn't really the point, where we started generating recommendations by organic systems, depending on which area is aging more. At the same time, each step involves actions you can take with breathing, the cardiovascular system, and more. You have 10, 15, or any number of things you could do to improve the health of that area, and a level of complexity appears, almost a heuristic way of saying, what is the priority? Even that priority, together with the user's desire, with that person's secondary goals, to understand, well, if I give them just one step, if I'm going to tell them just one thing, which one will be the most rewarding, but at the same time, as Javi points out, crossed with the statistical probability that the person will actually be able to do it. If I tell someone, go ride a bike, zone 2 for an hour, but they have prostate pain, I need to understand that variable to see what the most useful or convenient substitute is in that circumstance. I think that gradually managing to use the best of technology for substitution and to understand that will give us something that isn't a guarantee, but there's a higher probability that the person will be able to sustain it and get out of that slump.
And that's very good. Sebas, what do you think would be, in healthy people without any diagnosed pathology, the most cost-effective action that would initially change that person's health the most? Just one, I mean, what would you do?
Statistical probability. Considering probability,
They will fulfill it, considering that they will have adherence.
in chronic fatigue, to sleep. I will be there with Javi to optimize it because I know that through that process, the person will be able to improve other areas later on. So I'm kind of trying to get ahead of that cycle, now a virtuous one in this case, to achieve the greatest possible improvement within chronic fatigue.
You can't choose like that. I mean, you can choose not to eat, or even what you were saying, Borja, about I give you the order, you can't eat. People tell me, yeah, but I just wanted a little treat. No, you know what? You can't have a little treat. We're going to do 4 weeks where you can't have a little treat. You're going to follow this diet, an anti-inflammatory protocol. I'll give you this app so you can identify if what you're eating is a toxin or actual food, and you have to stick to it strictly. But when it comes to sleep, you say you have to sleep, and also,
The more the patient knows they have to sleep, usually the worse they sleep. It's true that you can't just press a button and sleep, except with psychiatric medication,
that's resting, that's not recovering.
of course. So, for me, you really have to take a more indirect approach because many times they even develop anxiety because of the insomnia, right? I can't sleep, I'm not well. I'm not well because I can't sleep. I anticipate the night and I get worse. You have to try to get them out of that in some other way. It's not that simple. Insomnia is one of the biggest clinical challenges for me.
When people come to my office, they tell me, or I ask them, do you take any medication, any drugs? No, nothing. Well, yes, clonazepam. As if saying, no, well, yes, the usual one, the standard one, I take it.
Many people don't realize contraceptives and similar drugs are actually medications, and when mentioned, they are often surprised to learn this. Red experiences this every day because of psychotropic drugs. But it's something very interesting from the perspective of challenges, if you will, to start correcting our behavior, which is a bit more representative of what will happen to the rest of the body and the rest of the time when we're awake. When I start correcting at the behavioral level, the alterations that are about habits and ways of thinking, they're both. Because you were asking, Borja, about how I approach sleep. Then I start to see positive results much faster in other areas, which is different from when I start doing it from the exercise side. For example, I get tired, like you mentioned before, I get tired making changes, the changes that I make, perceived intensity, I fall into deep sleep faster and I have more deep sleep time. So the million-dollar question is, do I have more deep sleep because I have tissue to repair from the damage I did? Or am I really improving? So many times there are small effects that we can take advantage of behaviorally and we can enjoy or make initial progress. I'm not saying to use a psychotropic drug to fall asleep, but many times if I need that initial process, I discuss it with Ro. Thinking of someone who is a psychiatrist, who practices functional medicine, who understands how to do the later tapering process, but who can use it as an initial crutch. Any of these.
What? Without a doubt, without a doubt.
Like to get to that?
Absolutely. Medications are meant to be used, and when taken correctly, they provide benefits. I'm not opposed to medication. All of us here talk about functional medicine and lifestyle as a priority, but psychotropic medication can get you out of that hole. Obviously, the challenge is to use it for just the necessary amount of time, not a day longer. That's where we fail, because many of them are also very addictive. But they're there to be used, just like in the field of obesity, glucagon-like peptide, 1S, and many others, right?
No, I don't agree with you there. No, glucagon-like peptide, one or anything that has to do with modifying our physiological components on a chemical level, which uses our own digestive resources to absorb nutrients and in that way try to lose weight. I understand that many times it's good, it's a help, it's a push. But I've seen some cases that have had side effects. There are many health professionals who are prescribing them without evaluating the liver or pancreas.
Yes, they're definitely being misused.
I'm going to play devil's advocate with you. I'm going to take a middle ground between your two positions to understand two essential things, especially from the point of view of trying to provide a bit more objectivity. One is objectivity. It's true that they're not used correctly, It's true that I don't know. It's true that the normal studied use case for a glucagon-like peptide, one agonist isn't lose 5 kilos for the summer. It never was. In fact, it's not intended for that. Does it work for weight loss in a more reasonable way for someone who is a candidate for bariatric surgery and wants to start with a more conservative approach? It's not intended for the average person who just has a few pounds of fat to lose, which is actually the most common use case. And on the other hand, I think there's another element that's essential to all of this, which is now we can have panels that measure whether we're using it correctly and whether we're accelerating or slowing down the rate of weight loss. A correct way, but there's an element that I honestly learned with Pulse, with Morpheo before Pulse, which was a bit conflicting, and that appeals a bit to understanding what is the probability. It's more about Bayesian probability, but it's about understanding what is statistically the most important thing to solve right now. And we saw it when we had a system before, where in order for you to access and understand how many calories you needed, you had to use plate identification and everything. You had to answer questions that were from eating disorder questionnaires to make sure that the person didn't have an eating disorder. And so that she doesn't choose to lose weight being a woman who weighs 40 kilos and doesn't have any excess weight. So what happened to us was that even though that's statistically real, the probability of people who have an eating disorder compared to the probability that this person is overweight and needs help. Because of metabolic flexibility, insulin resistance, etc., losing fat to improve their condition is completely the opposite. And what did you find? Regarding metabolic flexibility, did 80% of the people who aimed for that goal actually need that process? And what about the probability? The worldwide prevalence of eating disorders in women was %, and the number of people who actually used it was even much lower. Therefore, it ended up being removed by popular demand because people saw it as an obstacle, since the statistical probability was going up to 100%. From this perspective, it's interesting to approach it from that angle because we're thinking about the problem on a global level. There. Where do I disagree with your point, Javi? If you think about it on a macro level, everything you're saying is true, but it's also true that there are countries where 70% of the population is overweight, and there are countries that are heading in that direction, even if they haven't reached that point yet. And when we start to consider people who have a normal body mass index but have low muscle mass and a lot of fat, the percentage increases even more. Therefore, a tool like this has a very positive metabolic impact. From that standpoint,
we have to start from the premise that it should always be recommended if it's indicated. And based on Sebas's premise, most of the time it's used incorrectly. We remember type 2 diabetes and obesity, okay? So it should always be indicated when lifestyle changes have failed, meaning when training, nutrition, and lifestyle changes have failed. Unfortunately, that's most of the time in obesity when it fails. There are people, obviously. 27 doesn't need Wegovy or anything else. What they need are 3 adjustments, right? But someone with a body mass index of 42, like so many people who came to my consultations with this body mass index, sometimes there's no other way out than that, or bariatric surgery, there's no other way out. Obviously, it's not the optimal choice. Obviously, it has side effects that, on the other hand, are fairly safe. But there are people we really have to put ourselves in their shoes. They don't have many other options. I mean, they don't have any other options.
There are two things. When someone wants to have bariatric surgery, a clip, whatever it is, they have to reach an optimal weight before the surgery.
Yes.
That already shows you that the person can lose weight on their own because
with a goal in front of them, which is to have surgery. Otherwise, they won't do it.
That's a purpose. And we always talk with Seba. We always talk about purpose as number one in life, especially when it comes to health, 100%. But if the purpose, the surgery, the purpose could be healthy longevity. The right relationship with your children, with your parents, with someone, with a partner. And secondly, when you reduce the size of the stomach, you reduce your ability to absorb nutrients.
That's why nutritional deficiencies happen and why multivitamins are needed. Obviously, not in the optimal way, obviously, but we go back to our medical system. The way everything is set up, well, sometimes there's just no other option. There's always another way. But the way everything is set up, I don't know if I'm making myself clear. Yes.
But that's why I was telling you that my number one tool, when it comes to food, I mean, people stop eating because the only alternative is to eat junk, so they stop eating.
There's an intermittent one, you mean?
What happens is that the intermittent zone is what brought us here in human evolution, up to this moment. I mean,
Stop eating at night. Don't just skip a few hours. Yes, they do stop, leading to prolonged fasting. Open the windows.
having the windows much more. No, actually, it's the opposite. Close the eating window and open the fasting window. But eventually, if you don't eat at night, try not to snack. That is, even if you have a 5-hour window, you should have 1 or 2 meals, not 5, not 1 every hour. So this is where, as a tool, the only real tool that works for me is this one. Am I going to stop eating? Yes. Okay, stop eating. How much? As much as you can, as much as that person can. And when you are going to eat, try to start with one food, then we'll see how you handled it. You mentioned discussing a tool in reverse, so we could say, place it in front of you since it's food.
Yes. Well, that's ultimately a debate in which, in a social utopia, no one should have to use medication or surgery. Well, because they would have a personal trainer, a psychologist, a coach, and a nutritionist on top of them. And in the end, that's how people, of course, get results. You know how people achieve results? In my opinion, when there's someone accompanying them, holding their hand through the process.
When they get scared, well,
they can use the pumpkin deck of fear.
But he did a test on me. Look where my triglycerides are. I have low-density cholesterol, low-density lipoprotein, the so-called bad one, poor low-density cholesterol, which has so many functions. They've called it bad. Look, what do I do now? Am I close to a heart attack? And when they get scared, that's when they start, and for a while...
For me, fear is temporary. My poor father had his gallbladder removed due to cholecystitis. He tries to have good habits, but doesn't always succeed. And well, honestly, the first month he was very scared and stopped doing the things he shouldn't do. But after that time passed, he didn't anymore, no. And that happens to many other people because that's how humans are. In the end, we get scared. But if we don't feel bad right now, and a lot of subclinical pathology, and we don't feel anything good, we go back to our usual habits. And breaking that, for me, it's a job of months, years of re-education to close the issue. Ozempic and glucagon-like peptide, one are about to come out, probably in a year and a half, 2 years they'll be released. The combination of 2 glucagon-like peptide, 1 analog molecules with myostatin inhibitors. What it's aiming for is basically to eliminate the loss of muscle mass associated with weight loss.
That's interesting.
When that comes out, it's going to revolutionize all of this. But through follistatin, it does it through follistatin in the cascade downstream of myostatin. I don't remember, but basically at the muscle break level...
That's how it always was.
Are they monoclonal or what? Are they monoclonal? They must be expensive from the looks of it. And there's already a phase 3 underway. They did a phase 2 with monkeys, and they didn't lose lean mass. The monkeys didn't train by definition. Monkeys don't do strength training.
But they also maintain a much higher percentage of lean mass than humans do, naturally, under the same conditions.
We'll have to see in humans, but it looks pretty good, as long as it doesn't cause myocardial hypertrophy or anything else that would invalidate the clinical trials. Look here, Fede Martinez asks, what do you think about the recent benefits of Viagra and tadalafil for longevity? I don't know if you've heard anything.
I've heard about it. It's true that there's a lot of talk about it. There's a lot of talk because of the vascular dysfunctions that occur as we age, for which there are alternative methods. In fact, there are measurement panels coming. We talked a bit about this earlier this morning, Borja, but there are panels coming that will allow us to measure when we have cardiovascular remodeling of the heart muscle, which will help us understand if we are. They are used, for example, with nitric oxide metabolites to understand if there is vascular dysfunction. That's where we'll understand if a tool like this could be used. I still consider it a crutch, and it should never be ours. The mechanism by which you seek vasodilation, I think with that same logic you could use minoxidil, and we don't do that. So what we need to understand is what is the vascular dysfunction that is causing that damage in the tissues. Before thinking about using it for something like Viagra, like for aging and longevity.
Because if you keep following that narrative, you could use a lot of things for longevity, but the marginal benefit of that is not very clear to me. Not the extra benefit. With glucagon-like peptide, once maybe, but with things like Viagra or tadalafil, in the end, because of their vasodilator effect.
I understand, but the thing is, we're talking about the key. What door does that key open? If you're saying this tool helps improve vascular quality, in which patient, in which person?
And in which tissues? because it doesn't occur equally in all tissues.
So I think yes, because I've seen it and it can be used.
But have you used it? No, I haven't.
No.
Why?
Longevity or something else? No.
I don't need it, not for any of those things.
Okay.
No, imagine, I'm married. But beyond that, the reality is that you really have to understand for whom, above all.
Very well, very well.
And here they ask, don't you laugh because we don't take ourselves seriously? Here they ask if measuring glutathione after age 55, along with selenium, would be useful. Is it fede peres ton skini?
Measure or take?
It says measure.
I don't think measuring is right. It's not representative of our antioxidant capacity or our ability to detoxify xenobiotics either. It's much more useful to measure. There are already metabolites and biomarkers that allow us to start understanding what the effect of oxidation is on our body. Earlier we discussed antioxidants and understanding based on that. Well, if I overdo it with antioxidants, am I causing harm or am I preventing mitohormesis mechanisms, for example, to generate new mitochondria? Well, how do I regulate the right amount of antioxidants? For Borja, is that measurable nowadays? So are there biomarkers that allow us to understand that level? And based on that, I don't know. For example, they measure pre-lipid oxidation through, for example, urinary prostane processes. So they help us understand how much I'm oxidizing, what level of oxidation exists, and based on that, understand which antioxidants I can use, like glutathione, melatonin, etc.
All right. By the way, what do you think about the use of melatonin at anti-aging doses, at high doses? How much is that? They use it at 50 milligrams, 100 milligrams per day.
Just to clarify, in case anyone doesn't know the doses, 300 micrograms is the most standard sustainable dose. Meanwhile, people who take it to sleep usually take between 1 and 3 milligrams. Those are the most typical doses. Just so that anyone who doesn't know can get an idea of how exaggerated that is.
Also, these doses, which I checked recently, I recently looked into why and how much is used. And they come from allometry studies, which basically ask, how do you translate doses from animals that weigh much less to humans?
At 50 milligrams, it doesn't cause dependence.
50 even more, up to 100. This comes from allometry studies that try to translate the dose in animals, preclinical doses to humans, based on comparisons in weight and so on. But as you know, those approximations are quite inaccurate, and the truth is that there are few studies in humans with those doses in the end. That's why, honestly, I don't have a clear position on whether they are useful or not, but it does seem that they don't inhibit, in the end it doesn't inhibit production by the pineal gland. That does seem to be the case, but I'm not sure they have an advantage. For example, I'm really interested in the topical application of melatonin on the skin, because melatonin has a lot of benefits at the skin level. Locally, it seems to penetrate well since it's liposoluble. Well, actually, it's amphiphilic. Melatonin is both liposoluble and hydrosoluble. It has that dual capability. But when it comes to taking compounded formulas, which is what is usually done, of 50, 70, 100 milligrams, I'm not so sure about that yet. Hopefully more data will come out, because right now, no.
I know it's a combination with a drug that, obviously for everyone watching, it's very important that you are always supervised. But sometimes it's good to combine melatonin with diphenhydramine to help you fall asleep well. Melatonin helps maintain sleep a little, but it's a good combination. It allows people to rest without too much trouble.
Now there's a new drug, going back to pharmacology, called QBB, which targets daridorexant. Sorry, we shouldn't mention brand names, daridorexant. It targets the orexin system, which are proteins that keep us awake. And they are not addictive, they don't have the addictive effect of benzodiazepines, and they're also showing good results.
They don't make you hungrier.
I don't know if it's hunger, but they don't cause that addiction, that addictive behavior, which is very dangerous.
They also don't alter the deep sleep phases like benzos did.
It improves sleep architecture. It doesn't make it worse. Benzos clearly make it worse. They reduce deep sleep and rapid eye movement phase, and the superficial phase becomes longer. Like alcohol, something similar happens. Well, let's see. While people ask us a few more questions, let's open up another topic. For example, sweeteners, are you for or against them? Arguments for, arguments against, because there also have to be arguments in favor, right?
I'm always against sweeteners because they're hyperpalatable. So even though maybe some aren't so harmful or aren't harmful at all, if they're going to create a situation in your mouth that raises your threshold much higher, then later, When you eat something healthy, you won't enjoy it because
But then a mother comes to you with a 14-year-old child, a child with obesity, with 4 dental cavities who drinks, well, 2 liters of Coca-Cola, of carbonated cola drink or the traditional cola per day at lunch and at dinner. And the child says that he doesn't touch water, that it's impossible. What do you say to him, even if he asks, can I drink the 01? Yes. Okay, so they're not against it. No.
you're right, but I want to make it clear that I know how to listen.
Of course, yeah, it's not.
Besides, there are certain specific effects of some sweeteners. I think we're getting to a point where some types of soluble fibers are going to be used more and more as sweeteners, and they're going to have a relatively similar effect. They won't greatly benefit the microbiota, but they'll have a positive effect on it. And some sweeteners, I'll mention xylitol as an example, have an effect that is clearly positive on, for example, the microbiota in the mouth. So chewing a gum with xylitol, it has an effect of modifying the microbiota. It has an effect of, for example, providing metabolic capacity to bacteria that you want to develop, while at the same time you're not feeding pathogenic bacteria or bacteria that could cause harm to your body. So it's interesting from that perspective because paradoxically, we once thought those substances harmed dental health, but now we know they actually improve microbiota and reduce inflammation.
Sebas, I forgot to ask you something on this morning's podcast. If the digestive doctor diagnosed you with small intestinal bacterial overgrowth tomorrow, what would you do immediately? ABC, what would you do?
I would improve my gastric pH as much as possible, assuming that I have an alteration in that pH and that it's the reason why small intestinal bacterial overgrowth could have happened or occurred in the first place. For those who don't know why this happens, normally we have a pH in our gastric juices that is one of the most important elements for neutralizing the development of bacteria in the proximal part of the small intestine. So compensating for that is one of the most interesting factors. If I don't have gastritis, I would use betaine with hydrochloric acid. I would use about 648 milligrams, which is a pretty standardized dose for this. And then what we're seeing quite a bit, as we talked about urolithin A and several substances like postbiotics produced by bacteria, when they're good, well, part of that actually is that they work like postbiotics, but they're not. They are ursodeoxycholic acid, and TVSA, which serve functions of neutralizing bacterial flora. We don't want to develop that in that part of the small intestine. So those two supplements, the part that improves gastric pH and the part that improves bile acids, seem to me to be quite interesting elements to keep the bacterial flora in balance. Then, many times, people are automatically told not to take probiotics or are discouraged from taking them. It seems that nowadays we have the ability to understand which probiotics are going to affect which part of our body, and in that way, repopulating certain other parts of our body could be beneficial. It's not the first approach. When you think of small intestinal bacterial overgrowth, you think of rifaximin, which is an antibiotic, and you think of trying not to do anything at all that nourishes that bacterial flora, but I always want to take a step back and understand why it developed in the first place. And in most people, I find, at least when I was still seeing patients and saw people with small intestinal bacterial overgrowth, I find that connection you mentioned of chronic stress, of the vagus nerve, of sympathetic activity, inhibiting certain digestive processes, which are the reasons why that initial underlying mechanism develops over time. So I would think about a strategy for that. We talked at some point about breathing strategies to activate the parasympathetic system. I think more about devices that use electric current or swallowing neuromodulators, or on the neck, they influence vagus nerve activity. So we might say there's a physiological benefit, or perhaps it's simply restoring the balance between sympathetic and parasympathetic activity, allowing normal digestion. And then an initial aid, which matches a bit with everything we've been talking about so far, which is a crutch, not a tool to use forever, to compensate for that gastric pH and to compensate for that effect at the intestinal level of neutralizing those things.
Have you tried any transcutaneous vagal stimulation device at the tragus level?
Yes, but the neck.
Okay, yes.
No, well, Marks, but...
Of course, the one I've tried in terms of drinking and really with continuous use, it's true that it's not certain.
I can't talk about results because I didn't have a condition to say I can compare in terms of sleep quality or I can compare in It helps many people with panic attacks or digestive issues. Since I didn't have any of those, I can't say it improved me spiritually.
Are we talking about transcranial electrical stimulation, or did I miss something?
It's stimulation of an afferent branch of the vagus nerve through the ear, the tragus, I don't know. It's a clip that's placed with a specific frequency, a patented electrical stimulation that stimulates the afferent branches of the vagus nerve. The trigeminal, if I remember correctly, a branch that goes up and enhances vagal activation, increases heart rate variability, boosts vagal tone, and lowers sympathetic activity. So in anxiety, in digestive problems, well, it works well. Insomnia, it can work.
I was familiar with transcranial electrical stimulation, but I didn't know that the vagus nerve could be directly stimulated electrically.
It's about targeting anatomical sites where the vagus nerve is closest to the surface to apply electrical stimulation.
The auricular branch, of the trigeminal. No, the trigeminal is another one. It's different. No, for the microphone. Yes, no, of course. Going back to hypothetical situations, Javier, what would you do if tomorrow you get a blood test and see that your glycated hemoglobin is at 6.7%?
I stop eating.
It fixes everything. He's like an old school doctor, fixes everything by not eating.
It's just that many times, not with my body, but I have tried to fix glycated hemoglobin by improving fatty acids, right? Trying to increase ketogenic energy and cause a collapse. People, many times you say, if I raise ketogenic energy, I'm automatically going to lower glucose consumption, right?
You mean by working with fats, right? Yes.
Fatty acids. And the truth is, if you don't have good metabolic flexibility at the base. I've had people call and ask if I recommended a ketogenic diet, saying their wife fainted at the gym and asking what to do. Literally, huh?
Of course.
So basically, yes, but it's a progression, right? Start to decrease, let's see, glycosylated 2 things. It's diet, but I'm pretty tired, I was going to say another word, of talking about diet. Yes. And the other thing that I think is very important is cortisol. I think cortisol can raise your glycosylated hemoglobin. For those who don't know, it's an approximate 3-month record of how, in quotes, caramelized the blood of the red blood cells is. Yes. That's how the red blood cells are transporting and using oxygen and nutrients. So I think that when we have an adrenal system, right? All the time, like we talked about before, a hypertonic stimulus, as you called it, constant, the cortisol eats everything up. Since cortisol calls for energy because they're glucocorticoids, I think working on the vagal system, linking a bit with what we talked about before, lowering a bit, I think it could be a good tool. Do you agree?
Yes, I agree. Ultimately, cortisol takes glucose from the liver and releases it into the blood. In insulin resistance, that glucose isn't used properly.
Here I would add something that I think might not be so straightforward, but I think it's... Otherwise, we're always late. I always want to look at the mechanism that comes before, which helps explain why certain things are happening. And I think that's important because the sooner we find it, generally most pathologies or issues are easier to solve. And in this, I think we're looking at the wrong aspect. When we're looking at glycated hemoglobin, we're looking through a window to the past, which often doesn't help us understand the averages. And clearly it shows more than just insulin or blood glucose values. But with the current profile, we constantly miss the person who momentarily has disorders in insulin production or glucose management. What do I mean by this? When you have a person with type 2 diabetes, their blood glucose is elevated, even if they're using metformin, etc. It might be above 126, which is common, even though it's not correct. So, we end up exhausting resources, and that person might eventually end up on insulin over time if they can't improve and can't change those habits that we know could resolve or greatly improve their condition. When we go in the other direction, which is where most of our audience is, sometimes it's a bit elevated. I more or less understand what I have to eat. I understand that I need that metabolic flexibility. That's as far as we all get. But when we start to look back, there's the person who has high blood sugar, who's in what used to be called prediabetes. Today, we talk more about insulin resistance. We often see people who have a normal glucose range. I don't know, 95, for example, but their insulin is at 20 to keep that 95. And we already know that there's insulin resistance there. And if everything stays the same, it goes in that negative direction regarding the balance that would be shown by elevated glycated hemoglobin. And the whole story, but I think there's a step before that we never detect, we don't do it. The test is obvious, which is the oral glucose tolerance test, the test that's used in pregnant women, for example, where the question could be, look, you're making me drink 75 grams of glucose in a glass of water, and testing what happens afterward. But what ends up happening when we use that in practice is that we find many profiles of people who, when unchecked, had normal insulin and blood glucose values, but their response curve speed shows us that there's already some insulin resistance, which is seen when you're exposed to those 75 grams, but since you've never in your life measured your glucose or insulin after eating 75 grams of simple sugars, you never realize it. But still, people do eat them. So it's creating many scenarios that in the long run contribute to that glycosylated hemoglobin. Why is that important? Because maybe that person does things right the rest of the time, but momentarily responds poorly in terms of glucose and insulin. And there's small momentary spikes in blood sugar, maybe 150 or 180 glucose that you might have, and those spikes might last half an hour. They're not that long because you're not a person with diabetes or insulin resistance yet, but you're heading in that direction. And those are the spikes that, due to toxicity, make you bind that glucose to hemoglobin.
Yes, and with the oral glucose tolerance test, I went back and forth. Sometimes at first I would say, yes, it's useful. Then I started to say, no, because it's not something we usually do. And if someone does it because they're not healthy, then doing it is a bit traumatic. A positive result, or being told you have poor management, doesn't always mean you're actually managing things poorly.
Sorry, people do it all the time. People eat 75 grams of relatively simple carbohydrates all the time. It's something simple.
He means doing it at the doctor's office, not as a diagnostic test. Nowadays, I think that the A1C, which is obviously a very useful tool, is combined with implantable glucose monitors, the CGMs, which really provide a lot of information, and it's easy to use, non-invasive or minimally invasive.
Yes.
I'm talking about it because it's a test we're talking about completely different costs at the level of. Yes.
I also know what happened to me with 2 patients. It happened to me a long time ago, but with 2 patients who became obsessed.
Yes. They told me,
get me out of one because he was hurting me, man.
I had a patient who checked it 105 times a day. I saw him. I mean, it was almost a matter of constantly looking at it.
His wife called and asked me to take it away from him. He's so obsessed he grabs it even in his sleep.
Yes, that's the problem with giving tools to a population that's still healthy, especially those who don't have an obsessive profile. Because they get obsessed, they stop eating any source of carbohydrates, because obviously they realize that if they eat a piece of banana, their glucose goes up. In the end, they end up in a situation where they lose a lot of weight, have deficiencies, and so on. But well, they're the minority, of course. But it exists. You also have to manage the issue of obsession with gadgets and measurements, the metrics.
At one point, I became obsessed with this. I would fall asleep telling myself not to move, because if I did, it would detect I woke up and say I dreamed more or slept with a dream. It didn't mess with my head, and at one point I took it off. Now I'm wearing it a little bit for the video too. But beyond that, it's
common. Still, I've also taken off the watch many times because, for example, it would be 8 in the evening, the day wasn't over yet, but it told me I had 9,800 steps. I'd say, no, I'm not going to bed with 9,800 steps, and I'd go downstairs to walk around twice to reach 10,000. Yeah, that's how it is.
That's right, sitting down.
Of course. I used to get on the elliptical. No, but that happens a lot. It does. You have to get out of that.
Taking advantage of the climate of overdiagnosis and obsession, I think it's heading in a certain direction. The most important problem with overdiagnosis, all of this understanding that someone can go through a process that involves a lot of procedures to rule out diseases, which are quite cumbersome or quite intense, it also relates to the profiles now increasingly used to detect autoimmune diseases. What do you think about that regarding whether people just have more autoimmune diseases, or if there are false positives where things start to happen and people begin to restrict themselves from things that aren't necessary? Or do you just see it as detecting things earlier and that's all?
Is it a case of seek and you shall find?
Both. I think it's a case of seek and you shall find. But I also believe autoimmune diseases are more common now than 30 years ago, without a doubt.
And besides, testing positive doesn't necessarily mean that you're sick.
No, in the thyroid, it's very common to have thyroid autoimmunity, and most of those people never develop Hashimoto's in their lifetime. Only 10% of those who have positive antibodies.
Is that just statistics?
They also face higher risks of other autoimmune diseases.
Yes, without a doubt.
Wait a moment, sorry, I'm kind of taking over the conversation. No, it's nothing. It's super interesting because everything is interesting, but this is something I didn't know. You have statistically measured that only 10% of people with antithyroid antibodies end up being...
Yes, those are roughly the numbers in the series over time.
And can it have associated pathology?
The more you have, each autoimmune disease increases your chance of having another autoimmune disease. This is partly based on obvious logic beyond what is seen in the evidence, based on the obvious logic that when you have an exaggerated immune response to elements that are not a threat, which generally have those basic original mechanisms of binding, intestinal permeability, immunosenescence, all the factors we already associate with autoimmune diseases, this starts to happen. It starts to happen that it is statistically more likely, if you already have, that you have the same underlying mechanisms that can start to develop it in another specific tissue.
So you could say, because I'm going to go back a bit, I have seen, for example, many people with lupus, with a congenital genetic predisposition to develop rheumatoid arthritis. But you're saying that a person with antibodies or a predisposition to autoimmune thyroid disease can develop, for example,
It doesn't specify the disease, only that you have a higher risk of another autoimmune disease.
In the end, it talks about a dysfunctional immune system that isn't able to properly recognize antigens, and that can...
Dysfunctional.
Yes, clearly. And now why? Why is there a higher incidence of autoimmune diseases? Well, that's ultimately an open question. Obviously, our immune system is not well trained. Not from when we are born until we grow up. Well, the microbiota, the skin microbiota, the digestive one, is not properly exposed to those antigens it naturally has to fight against. We're getting cleaner and spending less time outside or getting dirty.
I think we're in an environment that isn't meant for our species.
No, without a doubt.
Without a doubt. If we are in a place where the aggressive factors are much stronger than the hormetic ones, we will end up having all kinds of dysfunctions. That's why I asked the more incisive question of whether autoimmune diseases are a failure or a failure of adaptation. For me, it's related to that. Sorry, This is the fourth podcast or the fourth talk that I've had in an environment with Sebi and other people, and I've also had it with just him, where I keep thinking and I'm going to keep standing by it, even though always. Then I get criticized by the critics, if you'll pardon the redundancy. They criticize me harshly. Criticisms. Destructive ones when I say I triple the redundancy so it's clear that they really go after me because I truly feel that it's not part of an autoimmune pathology if we don't have a coherent environment. Thank you. So, when a person goes back to basics, maybe that, of course, the predisposition will be there, but we'll never know what that percentage is. Thank you.
No, but we need to understand what variables make that happen. I think that summarizing them in the fact of changing the habitat avoids that problem, but maybe that's a reductionism, which I don't know if it necessarily leads us to, nor to fixing a disease that already exists, which is surely much more complex than preventing it from appearing, nor to making sure. If we reduce the risk, for sure, I think we all agree on reducing the risk, but it doesn't guarantee the possibility of eliminating that risk. Isn't that right? Why? Since I live in a cabin in the woods surrounded by nature and dirt, I have a healthy microbiota. Eating organic ensures autoimmune disease doesn't exist for me.
At one point in my professional life, I had a saying that I had tattooed, and it was this: genetics predisposes, but it doesn't determine, and clinical practice has shown me that sometimes genetic predisposition does determine, and strongly. I have changed the habits of people who...
Today, that's understood in a much more objective way. If you want like the vision, the implementation of that. In terms of advice, it's about taking your DNA, which can be done today. It's easy to do. In fact, and the messenger ribonucleic acid that is produced is measured, which basically, for those who don't know, you have a gene, and to turn that gene into a specific activity, you have a process. And in that process, ribonucleic acid is involved. Messenger, which has the advantage that if you have a specific gene and you measure from that same gene, messenger ribonucleic acid, it allows us to understand how much of that gene you are expressing in those specific cells. So, There you have a strategy that will allow us, it's still in its early stages today, but it will allow us to start personalizing that equation. Or those sets of recommendations that we already know, which today might be generic, to your specific genetic parameters, so that not only are you predisposed as little as possible, but you also express as little as possible. Obviously something that is pathological.
And you? Yes. That's why I'm asking Borja, you get all the tests done. If I could tell you at this table about all the possible tests to understand every molecule in your body perfectly, what percentage would you choose to know?
You know, the magnetic resonance imaging models that are coming out in clinics in the United Kingdom, basically, with extremely high precision, that measure you. That's very dangerous. For me, it's very dangerous. I don't know if I would do it today. It's very likely that they'll find some little tumor, but
is it dangerous for the public who can't interpret it, or just for Borja?
both, because I too, even though I'm a doctor, I'm human and I can also worry about something I shouldn't, because having knowledge doesn't mean you can't worry. You generally worry much more. Exactly, that's it. No. Being a doctor doesn't give you peace of mind. In the end, your mind overthinks much more. So I think something that extreme, like a full body magnetic resonance imaging, which at a near atomic level indicates a high probability of a positive result if something is present.
No, wait. A false positive is already something else.
It's very easy to solve. I don't agree, because even without the false positive, but let's take the false positive as the worst possible scenario. From a probability point of view, it's logical for you to choose something just to do a population screening and apply it to everyone. You would only want something that has a high probability of happening to everyone. Why? Because the moment you choose something that happens in 1 out of every 100,000 people, you already have a significant risk that those false positives will lead to treatments, costs, harm to the patient, etc. So in that sense, we all agree. Now, from the point of view of recommendation and prevention, obviously I am going to be aligned with that. I mean, yes, I would definitely do all of that. In fact, I do most things a bit empirically as experimentation on myself. But from the point of view of understanding what is the strategy to minimize that, possible mistakes. That often means, and it's important, you can't do it if you have that obsession with the product you use, with the metrics. All those people you mentioned obviously shouldn't go through these processes. They should be done by someone who has the ability not to get obsessed. Why? Because many times a score of 100 is unattainable, no matter if it's that resonance or if it's a genetic study or whatever it is. But it allows us to understand which of those 15 or 20 things that we can do, but we know we can't do them all, is going to be the most profitable for us. So, from that perspective, if I have the peace of mind to approach it without getting stressed, the information allows me to perfect that result and say,
Yes, what happens is that, for example, for me, the clearest example of this is genetic studies with the apolipoprotein E alleles that give you the highest risk of Alzheimer's. I think this is already the third patient who calls me extremely worried. Borja, I tested positive for these alleles. My mother and father had Alzheimer's. I'm scared. I don't know what to do. They're desperate. And the only thing I can say is, well, stay calm, optimize your lifestyle as much as you can because that's in your hands. But for now, we can't change your genetics, not with clustered, regularly interspaced, short palindromic repeats or anything else. So what then?
sorry. So yes, there is behavior. That's the difference, which is why do I get the information? How reliable is that information? There are several aspects that I think are key to keep in mind. One thing is that for all genetic studies, and this is also seen with microbiota and other areas, we are still in the early stages when it comes to interpreting the information. That means that many genetic studies, especially the more reasonable ones, have what is called a confidence score, which is how much this gene variation is associated with this specific situation. That can range from your phenotypic characteristics like eye color to certain pathologies. Continuing with the example of apolipoprotein E, which is among the ones with the highest confidence score and has been the most researched, it's still not perfect. It just means we have a bit more certainty that there is an association. That information helps me make a risk threshold adjustment. So in terms of behavior, I can't change the apolipoprotein E, but I can make changes for that patient. If I see a patient with that level of complexity and who wants to reach that level of perfection, which I assume one of your patients falls into that category, I can modify the apolipoprotein E to be adjusted to the risk profile. So I no longer want an apolipoprotein E of 80, I want 60 because their apolipoprotein E polymorphism, two different letters, B as in Bravo and E as in Edward, their apolipoprotein E polymorphism makes them more likely to develop Alzheimer's. So I know that I have to modify this situation, and at the same time I start to have other tools. They give a slightly more complete picture, like the one we were talking about this morning, which is the polygenic risk score, where we evaluate many genes to understand the cardiovascular risk profile. And they are much more useful for early prevention, but at the end of the day, if you want, could I do prevention without having those measurements? And I'm going to worry. Simply by having target variables that we know are causal, fairer, more specific, like lowering apolipoprotein E, which we know is much more associated with events and heart attacks. Unlike just low-density lipoprotein, which you mentioned before, that might not have such a direct relationship.
Well, we believe that apolipoprotein E is the protein that transports low-density cholesterol, the so-called bad cholesterol, so that's related.
I don't know, maybe someday I'll feel like doing a full body screening of everything that's...
I don't interpret it, so you don't get scared.
Yeah, no, but well, I think that also for specific conditions and knowing that there's a significant risk in your family, it can make more sense. For example, in my family, cancer is very common. I had cancer at age 6. My mom and grandparents also died of cancer. You? Yes, I had lymphoma at 6, look. And I know that's present in the family, so maybe in that case, I would accept the potential risk of more anxiety, right?
Today, understanding this for everyone and each person's background, isn't there also an approach on our part to understand the mechanisms? Whether it's cardiovascular disease, cancer, neurodegenerative diseases, or others, the approach applies. Don't you think there's also a responsibility on our part to try to address the mechanisms of aging, which we know make us more prone to those most related issues? That means, for example, understanding someone who has cardiovascular disease, trying to reduce aging or inflammation itself. Someone who already has genetic alterations at the family level, which make them more prone to a disease, trying to reduce what we call genomic instability. These are proposed as strategies that we can try to apply. I'm trying to put something together for Pulso. It's complex to find a tool that can stop a hallmark of aging that isn't a substance. It's difficult. But we have that strategy that still hasn't been fully explored from the perspective of longevity, from the perspective of disease prevention, to be able to say, well, this is the aging mechanism that's most associated with increased risk in this specific disease. So let's focus on the therapies or approaches that slow down that mechanism.
In other words, precision therapies. I think that...
I'm not sure if I think when you consider...
About seduction.
It's about optimizing your effort, your willpower, and your resources.
But for a purpose.
For a purpose.
Did you say that Pulso will be able to read blood tests? Yes. Tests of everything.
And biomarkers?
There you already have more or less the profiles they can give you.
It's not the same as the hallmark of aging. It's not the same as saying my telomeres are shortening faster than normal, which, in my opinion, is actually the least relevant of the hallmarks, but that you're developing dysbiosis. I think those are elements that don't define your health today, but they do define a future trajectory. And I think that understanding that as a risk factor for disease prevention is going to be interesting.
The first thing you suggest is trying to do prevention or improve longevity or quality in a specific aspect. Let's call it metabolism, your point of view. Do you think that's more productive? To focus a bit more, yes. To have a goal, to have a... How do you say it?
A purpose.
Yes, more specific. It makes sense.
Yes, it does. I like it a lot. Also, what Brian's team is trying to do a bit is to achieve elite scores in all organs and systems.
Yes, but it's missing the tool that can be transferred to the public.
Yes, obviously they do it with one person, and it's not democratizable. What they do is far from being that, right? It's far from being that. Carmen asks us, what worries you most after turning 40? Losing muscle mass, VO, 2max, or mobility? I'm worried about all of it, Carmen. For me, VO, 2max means longevity. It means the amount of life. But muscle strength means quality of life, and I think you need to have both. What worries me? On a population level, probably the loss of muscle mass, which is what kills people. People die in the hospital because of loss of muscle mass. And it doesn't matter which ward you're in, whether it's cardiology, pulmonology, or internal medicine, they die from sarcopenia. So I would focus on that. Obviously, VO2 max is extremely important. But for the demands of a person in the West, what they usually do, like carrying a few bags, going shopping, seeing their grandchildren, things like that, you don't need a VO2 max of 60 either.
So I would say strength, maintaining 60 in your 30s if you keep training,
You might reach 48, of course.
and that at 85 around there, you have 30-something, which allows you to be absolutely independent. And you mentioned something about, I still remember it a lot from my time working with hospitalized patients, where you see the reduction in saturation. And you also understand that in cases of acute illness, where there will be a restriction of VO2 max, having the best possible baseline is what helps you survive the most. COVID, that's when it will matter.
Who survived COVID? Those who had better VO2 max? Yes, absolutely.
Still, all three things were important. Mobility may be a second priority, but it's key for injury prevention, which we know will occur.
For muscle pain, and mobility is really important.
Mobility, circular flexibility,
Yes.
0% importance.
No, extremely important. 0%.
No, subscribe.
Yes. Well,
That's injury prevention number one.
Know that, let's see, you can be flexible, but compared to oxygen with the layer.
nothing.
No, well, he set up a podium.
On a podium, it's the third for me. Well,
By far the third.
yes. On a podium, it's the third. But well, in the end, strength and V2 max go hand in hand. I think it's easier to improve strength across the population than V2 max, because I also see, due to osteoarticular problems, I see very few. You don't need to run to boost your V2 max. Using an elliptical or another low impact activity can help too. It can be done in many ways.
Do you need it?
You need it for the bone, no doubt.
You need it for bone anxiety.
You need it for the bone. But it's true that the number one complaint from a 70 or 75-year-old patient is, I can't run because my knee hurts, because my hip hurts. Walking? Of course, but walking won't improve V2.
Earlier mobility wouldn't have happened.
Walking doesn't improve V2.
Get on an elliptical, but then walk. You need the impact too.
That's for sure.
But you need some challenge. Conceptually, the idea would be that you need to perceive the reduction of that V2 max at the level you need to feel short of oxygen for your base capacity to increase. Without hitting that threshold, the stimulus won't occur. It's all adaptive mechanisms. The example I always give about this is the oxygen saturation people have at the top of a mountain, where, for example, they're climbing a 7,000-meter mountain. They arrive with an oxygen saturation of 59 when you'd have sent someone to intensive care at 80. So understanding those adaptive mechanisms and understanding that this person obviously comes down with a much higher VO2 max afterward, and that even though it takes some time, if I do it continuously, or knowing that I have that reduction in available energy as a triggering mechanism to stimulate mitochondrial production, the use of energy and oxygen afterward, etc. Understanding this helps you quickly identify which exercises will boost VO2 max and which won't.
I just add a bit of spice, that's all.
Yeah, go ahead.
I'm going to ask you a question I asked Sebastian a long time ago. Podium, I like it, I love podiums.
Today we've made quite a few podiums, and now we could talk about some of them. Well,
I think we need to improve something. Any of the ones you touch will improve something because you're missing everything. Let's suppose there's a sick person. Exercise, muscle, nutrition, of course. Rest, that's right. Sun exposure and proper management of cortisol or stress.
okay. Rest, exercise, nutrition, stress, and what was the other one he said? Sun exposure. They're all important, and maybe I'd put sun exposure and stress on the same level, not one above the other. But at the beginning, rest is essential. Without rest, the body doesn't work. There's no way. Even if you exercise, it doesn't matter. Physical exercise is really the most powerful anti-aging action. There's nothing else. No. Or far from second place. Nutrition, obviously. However, I see people whose diet could be much better, but they have very good health simply because they do well in the other areas. I see people who eat poorly, even some who drink a bit, but they have a lot of social connections, a really good attitude towards life. They sleep well, they train like a beast, and in the end, they're healthier than the person who just has a bite of toast for breakfast every day, but doesn't do any of the other things, you know? Well, but you get the idea, right? I mean, in the end, health is multidimensional. When you get obsessed with just one aspect but neglect the others, you don't get better results. I mean, when it comes to health, it's better to have an 8.5 or 8.75 in everything than a 10 in one subject and just a 5 in another.
8.75 is good, since I would have been fine with a 7.
Totally, me too.
6 or 7 is trendy now. You can see it. Do you agree? In terms of order, yes. Yes, I remember a different order from you. Maybe you're changing a little bit. And maybe that's because Borja is here now.
He probably doesn't remember, Laura.
Let's go to Spain when he said it.
Sure. No, but I do see that a lot. There are people who get really obsessed, and I even think there will be another diagnostic category very soon for people obsessed with health optimization, okay? And we are also partially responsible for that. In that obsessive profile, I mean, I have patients who have told me, Borja, I live in the north of Spain. I won't say the place so there are no references. And since you told me that cold is a good hormetic stress, well, I've turned off the heating and keep my house at 15 degrees every day, right? And I say, wait, but is it necessary for the house to always be at 15 degrees? No, so you have to optimize, but in an effort to optimize everything, absolutely. For example, this person wouldn't go out with a friend to have a drink because that meant he wouldn't have dinner at home and would eat worse. He lost a lot of the social aspect. He lost a lot of connection. And health is not just about nutrition and exercise.
Do you know many people who are positively obsessed with health?
Yes, for better and for worse, for better and for worse.
No, I mean the other way around. I wanted to ask if you know a lot of people, either patients or acquaintances, who are obsessed with being healthy.
I do. Obviously, at a certain level, it's a bubble because I see that kind of people. And if you go out on the street, most people laugh at that, but I do have them. They come to me, and in the end, they watch our videos. They watch yours, they watch mine. And well, they hold on to that. And there are people who go too far, and there are people who get hurt by that, and it affects other areas of their lives. And then we have to be the ones to say something ourselves. No, stop. You can go out with your friends, have a piece of cake. You can skip a day of high intensity training. You can just go for a walk. You have to bring them down because it's easy to get caught up in that cycle where, well, you see results and you want more and you want more. It's the Brian Johnson model once again. Sorry for mentioning it so much, but it's the same thing. It's about having a score of 100 in everything, but life isn't a video game. Sometimes you have to have a score of 80 or even 30. If you're dealing with a breakup, your child is sick, your father has died, or any hardship, and you don't see each other. That type of patient or follower, I mean, you don't have that.
Do you know which comment comes up the most? At least the one the guys from the agency keep sending me like hotcakes.
An agency handles all your content, got it. Yeah, do you want to know?
Do you do the voiceover?
Yes, my content. I don't have an agency for the YouTube channel, only for other projects.
You too? Yeah, I already knew. Well, yeah. I think I should help him.
The most repeated comment?
The most repeated comment is, in the end, they're going to drive us crazy. One day it's one thing, another day it's something else. First it's good, then it's bad, this is healthy, now it's harmful, and in a way, they're right.
And I understand that comment, I do, because when you go online, it's a flood of contradictory information that obviously has to drive the poor followers crazy. But there's not much harm we can do here. Everyone has their own judgment. I think my judgment is based on scientific evidence, but I don't know what the other person's judgment is based on. I think that, well, in the end, when the audience gets some experience, they can tell for themselves if someone has a scientific approach or not. If someone is using alarmist messages just to get more views or not. I think in the end, most people realize that. But I understand that people are fed up with contradictory and alarmist messages, and I really do get it. I mean, I'm not a defender of how things are often done on the internet, because in the end, well, this is off script, but it's difficult.
I think the positive side of this is that all the personalization tools that keep improving, which are still lacking and obviously not enough yet, but all the tools that will give us personalization over time will provide an explanation to the person who says, but someone told me one thing and now someone else tells me another, and another person tells me something different. Which one should I follow? It's even possible that both are true. It's not even necessary for both to be wrong or for one of them to be wrong. It's possible even in terms of probability that both are true for different situations. So the question is, what is this person's scenario? Personalization is important, which is why your point this morning matters.
That's why I mentioned the nutritional pyramid. People like pyramids and being told what to eat. But informative messages like the new pyramid don't work for everyone. They put whole grains or carbohydrates at the end, I don't remember which sources, and at the base, fruits and vegetables. If you only give a triathlete fruits and vegetables, they'll die. I mean, someone who needs to eat 5,000 calories a day to meet their requirements, how are they going to eat only beef, fruits, and vegetables? They have to eat carbohydrates. They have to eat carbohydrates. So in the end, personalization is essential in health. It's essential, and sometimes people don't understand that. But it's also essential to do responsible outreach. And any message we give, even if it's the most scientific, the most polished, will be wrong for a percentage of patients. I discuss my fat loss videos, knowing a 16-year-old patient with an eating disorder who refuses to eat may hear them and be hurt, but I can't control that. But we have to be aware of what we're doing, right? I make a video about gaining muscle mass, and a 21-year-old guy with muscle dysmorphia is going to hear it, of course. So I think that's a sad point, but it's non-negotiable when it comes to sharing information.
It's information, and information is for people who want it and who can use it, and for them to interpret it as well. I don't know if we have that much responsibility now. If you have someone in front of you that you want to help and you have the tools to do it, then yes, you should individualize to be redundant, because otherwise there's no other alternative.
And that really highlights the value of what you do every day, which is consultations, the clinic, because in the clinic you do have direct responsibility for that person. Obviously, you're not going to tell a kid with bigorexia, get obsessed with muscle and gain muscle mass. But of course, in front of a screen, sometimes the messages are what they are, and we have to keep that in mind too. Guys, here's another important topic that's widely discussed on social media, and many people are unsure if it's useful. Are we missing something, or are there real benefits? What do you think about cold showers or cold exposure? Personally, I have a cold plunge at home. I think now, I don't know if you've seen it on my story, but I usually get in at about 5 or 6 degrees Celsius 2 or 3 times a week for 2 or 3 minutes each time. It makes me feel really good. It helps me a lot with my mood, my focus. It lowers my anxiety. All of this is totally subjective. It's basically a study with a sample size of 1. But what do you think? What could it bring, or what do you all think to a society that suffers from too much comfort, right? Well, exposure to something as uncomfortable as the cold.
I think it's super necessary, but it's not very applicable. What usually works best for me with people is to start lowering the temperature. Seba has a device that cools your bed. And it's good because that's going to help you start anyway, row. He also says it's hard for him because it sticks to him since he's cold.
No, he can select that. That's not true. He can select the temperature.
But I think the cold is necessary even if it's just to stop heating. Another thing, right? I say this and they tell me, come on, come live here for a night in Bariloche, Antarctica, with minus 20 degrees Celsius. Let's see if you can handle it. I'm not saying people should freeze. What I'm saying is, yes, let's not overheat. I think it should be 18 to 20 degrees. 22 degrees 18 at the lowest, 22 at the highest is a good temperature to get ready and finish your shower with a cool chill. Finish the shower by lowering the temperature, let's say, and in the winter, or see if also in summer.
Yes, I do it in summer and winter. It's winter in Spain now, and I admit it's harder for me, but also...
And the other way around? In summer, a hot shower?
Well, that's what I have the sauna for. I also really like the sauna. In fact, I tolerate the sauna worse, or it's harder for me than the cold. Look, the sauna at 80 degrees is hard for me. I've managed about 20 minutes per session, but it's tough for me.
That's enough.
The last few minutes are tough for me. It's like, I want to get out of here. I want to get into the cold. Yes, but in the end, they're hormetic stressors that I think at least give us the message that we live very comfortably, that we need to step out of that homeostasis from time to time.
They're not the same kind of stressors. They don't have the same intensity as stressors.
I think they're opposites.
No, I mean how much stress is generated by exposure to a 4-degree cold plunge. More or yes, it's less, the least yes, but more or less. A 15-minute sauna exposure as a standard figure does not have the same level of stress and impact generation for your body. That's why, if I could make an adjustment, in my opinion, it's that they don't need the same frequency, and the cold plunge or exposure to cold I would lower its frequency compared to the sauna, at least in terms of the evidence I have and the experience I have. And I think another small adjustment I would make is to check how much stress I'm normally exposed to know how much I can handle or not, without a doubt, in both cases.
If I have to choose, I choose sauna. And look, I actually like the other one more, but I choose sauna because it has more evidence, because in our society where cardiovascular disease is the #1 killer, it really helps in that sense. And because it helps with rest. The sauna, especially if you do it in the last hours of the day, helps with rest. Cold does not. Don't get into the cold before going to sleep because you won't sleep more. Cold is for the morning. But the sauna is very relaxing. In the end, it causes vasodilation. It helps you to fall asleep and to have a deep rest.
And release toxins. I think the stimulus is different.
No, the thing about toxins is super important. It's one of the few things we have to release xenobiotics through sweat. I mean, there are very few things beyond what our liver and kidneys do to eliminate those toxins. It turns out much more is removed through sweat in the sauna than we thought.
I'll also mention the tagging of proteins for destruction. Remember, we have the host cell protein 70. So, when we exceed the exposure to normal sauna temperatures, that's why studies are always done at 70, 80 degrees 80 is about the ideal number from a result standpoint. Simply because there is more evidence studied for that number. But going beyond that, we know it helps us eliminate, to tag and destroy proteins that are no longer needed.
And why are 20 minutes okay compared to 15?
Because that's basically what the Finnish studies say. Yeah, well, they mention sessions of 15, 20, 25 minutes 3 or 4 times a week. And in fact, they say there's no ceiling, that the more the better.
A very interesting thing about the Finnish studies is that since so many people normally use saunas, the benefits are not compared between sauna users and non-users. The benefits in the largest studies are between those who use it once or less versus 4 times. In other words, the comparison with 0 in terms of benefits would be even more significant.
Because in Finland, everyone has a sauna. There are 5 million people and 3 million saunas.
Oh man, no doubt about it.
1 for every 2 people.
Do you have one at home, Javi? No.
In Finland, everyone has one.
For wet.
No, dry. Dry sauna, yes. The wet sauna has...
Do you have dry?
Yes, dry. The wet sauna is fine, but it has fewer benefits. It has a lower temperature, and in the end, because of the high relative humidity, you sweat less. What you want in the end is to sweat too, besides.
Well, but with the wet sauna, you also sweat.
Yes, also, of course, also.
What do you do after leaving the sauna?
Well, ideally it would be to do a contrast therapy, cold heat, several cycles, but...
How do you do the cold part? Don't you get in?
With the cold plunge, no.
But from sauna to cold plunge, no.
Yes, of course. That's the contrast. That's the contrast plus the stressor. Do that at home. No, don't do it immediately, but yes. And you don't have to do the cold plunge at 3 degrees. You can do it at 12 degrees. But contrast therapy is getting out of the sauna, getting into the cold, going back into the sauna, getting into the cold.
An infrared sauna, I didn't hear you mention it. Yes, actually.
The one I have at home. We have one in the common areas, which is...
Borjas is modern.
Yes, when he comes, he'll try it. But the one I have upstairs at home is infrared. The infrared one has a much lower temperature. It goes up to 55, 60 degrees at most, no more. And in the end...
The effect of the infrared wave penetrates deeper at a greater depth. Yes.
In my subjective experience, it seems to have more benefits at the muscular level. For muscle relaxation, you feel knocked out. You sleep much better when you do it.
Doesn't it burn your skin?
Yes, if you get too close to the heat source, yes, because a regular sauna heats the air and the air hits your skin, right? But this has a heat source. You can get burned if you get too close. So, well...
The sun doesn't burn you, doesn't tan you. It's not like...
The
lamp we used to use.
No, it burns. Be cautious, especially if you plan to get laser treatment on your skin after a sauna, as the laser can burn you. Take extra care. But anyway, these are strategies that I think are interesting.
What?
To remove your hair, the skin laser, to get rid of body hair, I mean. Yes, laser hair removal.
What do you think about that?
What does that have to do with it? But I did do it. I did do it.
Do you think it could have any effect?
Good question. Let's see.
I've had 16 sessions of permanent hair removal, not on my arms, but it worked halfway.
Where, Javi? People want to know.
So, well, we had a machine, then we sold it, but it was the best on the market at that time. Now there's a better one, but after I did 16 laser hair removal sessions. Laser? I said, I'm not going to start researching, because I read a study in passing and I said, I'm not going to start researching because it's going to fry my brain.
There's little evidence of harm, maybe an isolated study, but not much overall. Do you think it could have consequences?
It's very powerful.
Look, this is like when you start talking about tattoos. Now, a Galician researcher I know, whom I met in Switzerland, has done a study that evaluates how tattoos immediately affect the lymphatic angles and suppress parts of the immune response. So, of course, people with tattoos are shocked thinking about their immune system, but well...
Honestly, tattooed people don't care much. I treat them all, they're all tattooed. I love it. And heavy metal too, I love it. That's fine.
There are already inks without heavy metals. That's more of a poor quality choice, but it's not mandatory. You can find inks without heavy metals.
Recently, it's not due to heavy metals, but because they remain in the lymphatic angle and appear to alter the immune response to some vaccines. There, it enhances the effect of certain vaccines, and other vaccines suppress the response of those vaccines. So, and it's more dose-dependent. The more ink, the more effects.
There is an issue of autoimmunity.
Yes, an issue of autoimmunity. How many tattoos? I have 2 tiny ones, but I don't think they made much difference since they're so small. But, well, it's not that... Anyway, in the end, well, everyone... I don't know, huh? Whether the laser will have any long-term negative effects? If this has really been done for quite a few decades, if there was something serious, I think it would have already been seen because there are millions of people who have done it, especially women, right? Who usually do it as a rule. So no, I don't think it's a threat, but you always have to keep an open mind, you know? I always say that...
No, after everything I did to myself, I'd rather have nothing. I saw that study and thought, no, I'm not looking at this. I'm one of those people.
Overthinks, right?
A little bit.
Yeah? Sebas, no. Sebas, a calm river, no.
No, don't overthink it.
Not in health?
Not in health.
In other areas, not health or work?
Yes, he wanted to give me a full-body magnetic resonance imaging. He told me, do it, it will be good for you. I told him, I don't have the guts to do it, because the results later you have to, whoever seeks finds.
Yes. Well, so guys, that's it. It's been an hour and a half, right? Almost of conversation. Very pleasant. I hope we do this again, whether it's here in Spain, wherever you want, okay?
I think it'll be in Malaga at Dr. Borja Bandera's sauna.
Oh, perfect. You know we're doing sauna events in Spain with followers where we chat like this inside a sauna too, and with cameras?
Yes.
No, with towels. For now, with towels. Maybe we'll do a very important person one. No, we do training. We also do events where there are cold plans, cold exposure, sauna. They're usually at a spa, right? And we have that opportunity to be with people. I was telling Sebas yesterday, what people are missing these days is being together and with us physically in person. They're fed up with digital stuff. It's normal. Everything is digital. We should restart those events. Whether it's like a conference or something more relaxed, more family-friendly, more personal. Well, guys, this has been a very relaxed, very pleasant talk. I hope we do this again very soon. And that's it. Let the audience tell us what they think in the comments. A big hug and see you next time.
Greetings to everyone.
Bye.